here in Copenhagen. I am a general surgeon at VA Boston. I'm the chief of surgery for the VA Boston healthcare system, and I'm a professor of surgery at Boston University and a faculty member at Harvard Medical School. I practice the full spectrum of general surgery, but I have a great interest in hernia surgery and have really done the full spectrum of hernia surgery and have combined my interest in surgical infections with hernia surgery and have explored this whole area of surgical infections and hernia outcome.
Sounds pretty interesting and intense. So, are you into robotic surgery as such in your own practice?
So in my own practice, I'm not doing robotic surgery. I don't think that, I'm not convinced yet that there is a place for robotic surgery in inguinal hernias, but I think that the field within abdominal wall reconstruction is really very appealing and very promising.
Right. So, when you're talking about your interest in surgical infections, so the immediate question that arose in my mind was, why wouldn't you explore robotic surgery, especially in incisional hernias, as a way to reduce SSIs?
So we've reduced SSI tremendously with laparoscopic surgery. And I don't think that the robot is going to offer more advantage over laparoscopic surgery in terms of surgical site infection. However, it is going to offer an advantage in technical advances and doing a better job and being more ergonomic than laparoscopic surgery.
All right. So, essentially, what was your research on surgical infections? Your topic, if I'm not mistaken, was the long-term effects of infections on implanted meshes. Would you tell us about that work?
So let me tell you how it started. I've had a long interest in surgical site infections, and we've done a lot of work in that field with different antibiotics, with different approaches in preventing surgical site infection. And then, when you notice that you have a high rate of infection with ventral incisional hernia, it makes sense to combine the two fields and try to really prevent mesh infection. And this is the subject of our most recent research, where we looked in 100,000 patients.
100,000 patients?
100,000 patients on the effect of surgical site infection on long-term mesh infection and then explantation.
I'm not sure your voice would be strong enough, so can you say it a little louder? Sorry about that. I'm a little loud myself.
100,000 patients that underwent hernia repair with mesh that we followed prospectively over a period of 5 years.
These are like real patients. You didn't just look at the charts.
This is a retrospective cohort within the VA system.
Okay.
And, there's no way to enroll 100,000 patients in a large prospective randomized trial. But what we have the advantage of within the VA system is to have this prospectively collected database of patients, and we were able to look at the rate of surgical site infection, follow them for 5 years, and find out who had a mesh infection.
And what was the answer?
So the rate of surgical site infection in general within patients having having hernia repair was about 6%. And for those, I'm sorry, it was mesh explantation was 6%.
Right.
And then the biggest problem was with deep surgical site infection. In those patients who ended up having deep surgical site infection, the rate of mesh explantation was close to 30%.
Wow. 30% of
30%.
Those who had deep infections?
Of deep surgical
site infections
at 30 days.
What about organ space infections?
Organ space infection was a little bit less at about 23%.
And from what I understand, these are all comers, like onlays, sublays,
Correct.
underlays, everything.
You're
We don't know
absolutely right.
exactly.
Those are all comers that underwent a mesh implant.
Right.
But what is amazing is that if you get an infection within 30 days, you're still at risk for 5 years for
Wow.
having a mesh explantation.
I would want you to say this again because it's such a strong message.
Yeah, absolutely. You know, if again you get an infection within 30 days, and this is what we're tracking within all our, practices, up to 30 days. If you get that infection with your hernia surgery, the patient is at risk of developing a mesh infection and explantation within 5 years.
So, what kind of infection are you talking about? Only deep infections?
Surgical site infection,
Any?
superficial,
Even?
deep, and organ space.
Oh my God.
And
That's
but the
phenomenal.
highest rate was with the deep surgical site infection.
Okay, so there is absolutely nothing that is minor here, correct? In terms of
Absolutely not.
SSIs?
Absolutely not. So, you get a cellulitis, you end up categorizing it as a superficial surgical site infection. It still puts the patient at risk.
So, what can I, as a surgeon, do to reduce this disaster from happening in my own practice?
That's a very good question, and I think that's the crux of the matter here. You have to apply all preventative measures to reduce the risk of surgical site infection. What we have found is that if you get an infection with one organism the first time, you end up with a mesh explantation and you have to reoperate on the patient. A quarter of those patients are at risk for another infection with the same organism. So, for some reason, that organism stay within the soft tissue.
Even though the mesh is out,
even
the
though
bug
mesh
still
is
stays.
out, even though the mesh is out.
Wow, that's
So
amazing.
you have to realize that and Staph aureus was the most common organism. You have to prophylax against gram-positive organism and reduce the risk.
And did you find that the obese and the smokers and the immunosuppressed were at greater risk for this kind of situation?
So patients who had a higher ASA between 3 and 5, patients who were smokers, higher BMI, were definitely at higher risk. Those were the most prevalent risk factors in our multivariate regression analysis.
Okay. And are you going to track these patients beyond 5 years?
I think it is difficult to do it beyond 5 years. A lot of those patients are elderly, and it's very difficult to track them beyond that.
Okay. Okay. Thank you so much for this conversation, and we look forward to more publications and more work.
Thank you, Ram. Thank you.
Good morning. So, ladies and gentlemen, introducing Dr. Kamal Itani, who is a surgeon from the United States. So, Kamal, why don't you
morning, Ram.
tell us about where you work and what kind of work you do?
Great. Good morning, Rama. It's great. And over. And we looked at those organisms. The majority, 87%, were gram-positive organisms, with 90% of them being Staph aureus, with the majority being methicillin-sensitive Staph aureus, an MRSA in just 4 patients. And there were 3 patients who had subsequent E. coli, and 1 was Pseudomonas. So we concluded from that part of the study that it is very important to identify the organism at the first infection and treat that initial infection completely before undergoing another repair. And when we go back to re-repair those patients, we should target the same organism. And in patients who are colonized with Staph aureus, we should think about decolonizing those patients and target the Staph aureus in our prophylactic antibiotics. So what I would recommend and what I would conclude here is that surgical site infection in all its forms lead to worse than you can imagine results. Nobody has done this study for over a 5-year period of time and followed those patients for a long period. So we had 332 patients who ended up with a mesh explantation because of infection. 58 of those patients never had any subsequent repair. Then we had 274 patients who had a first subsequent repair. And the majority of those had a single stage repair, probably the mesh was infected. They took it out, and in order to prevent a hernia, they did some kind of a repair with suture repair or biologic repair, and I'll show you the data. And 16% had a multi-stage repair, and this all occurred at a median of 195 days. Then among those 274, 50 proceeded to another second subsequent hernia repair. This occurred at a median of almost a year after the first repair. And then from those 50, 8 proceeded to a third subsequent repair at a median of 237 days. And then another 2 had a fourth repair at a median of almost 3 years. We don't follow those patients. We don't know what happens to them. They just present to us with their 9th recurrence or 4th recurrence. But why is it happening? A lot of those patients are having infections in the first place. Then you can see that among those who had the first repair, 154 had a suture repair, that's 56%, and then 30% had a biologic repair, and 12% had a synthetic repair. Almost the same thing with the second repair. You know, some had suture, some had biologic, and some synthetic. And what is very interesting is that when you look at the first subsequent repair, 23% of those patients who had the first subsequent repair had another infection. And 36% of those patients had to have another mesh explantation. And then you look at those patients who had a second subsequent repair, 28% of them had another infection, and 11% had to have their mesh explanted. And in the third subsequent repair, 23% again had another infection. And then if you look at all the complications that have happened, and we've divided them into groups: no subsequent hernia repair, a subsequent hernia repair with mesh, and subsequent hernia repair with sutures. And if you look at all the complications that have happened on those patients: chronic wound infections, sinus tract, fistulae, chronic open wounds, wound dehiscence, seroma, others, they occur in all those patients group with different percentages, but all of them are present everywhere. And then look at recurrence. Now, of course, in those patients who had no subsequent repair, the recurrence rate is 100%. But in those patients who had a mesh or suture repair, the cumulative recurrence rate is about 50%. So, in patients with no subsequent repair, or in patients with subsequent repair, the occurrence rate of surgical site occurrences is about 36%. And mesh explantation due to infection occurs in a third of patients after the first subsequent repair, and 11% in patients after the second subsequent repair. And the overall hernia recurrence rate after subsequent repairs is 50%. So we wondered if that organism, that percent. So we really have a problem, and we have to address this problem. And it all starts with the initial infection, surgical site infection. And we have to find ways to prevent those surgical site infections. And if you look at all the risks and put them all together, there are hernia characteristics, risks such as size and duration. You have procedure characteristics such as the hospital, the duration of surgery, the surgeon's experience, and the technique that you're using. And then you have the patient's comorbidities, and we all know what they are. And then this study that we just published a few months ago, and you look at the results from surgical site infections within 30 days and the rate of mesh explantation, you find out that if you have a superficial surgical site infection, the rate of explantation is 6.8% at 5 years. With a deep surgical site infection, it goes all the way up to almost 30%. And with organ-space infection, it is 21.8% at 5 years. So surgical site infection, whether superficial, deep, or organ space, is going to result in a mesh explantation almost 30% of the cases within 5 years. And this is the longest longitudinal study that has been reported so far. And this is true for inguinal hernias, it is true for umbilical hernias, and it's true for ventral hernias. And you see here that the deep surgical site infections have the greatest impact on mesh explantation. And this is a slide that Mario showed a little bit earlier today. This is coming from our study, and it shows you that even if you have an infection within 30 days, the mesh explantation is not going to occur immediately. It's going to continue over 5 years, with the median being at 208 days. And in a multivariate logistic regression analysis of all those patients who had a mesh explantation, we found out that the risk factors are an ASA of 3 to 5, the high BMI above 35, smoking, umbilical hernias, and ventral hernias. So we concluded from that part of the study that mesh explantation for infection is most common after ventral hernia repair, and the occurrence of a surgical site infection within 30 days is highly correlated with later mesh explantation, all the way up to 5 years. And it is very important, and this message has been said before, to optimize the patient's risk factor and adhere to SSI prevention. A month after a recurrent ventral incisional hernia repair, and you can see the soft tissue infections and sinus tracts on the abdominal wall. And when we went in, there was a PTFE mesh that was floating in pus. This is now a recurrent hernia. Another nightmare that we had to deal with, patients with diabetes, chronic renal insufficiency, and had a hernia repair, developed a surgical site infection, and then came to us and we did a laparoscopic repair, and unfortunately this is what happened. Now he has an exposed mesh that's infected, and if you look at the right lower quadrant, you see a trocar site where pus was coming from. Another nightmare, a patient who had a ventral incisional hernia repair has a recurrence, a chronic wound, and intertrigo of the skin fold. And then this nightmare, a patient who had repair of a stoma site hernia with mesh, and then the mesh eroded into the appendix and created a intracutaneous fistula, chronically infected mesh, and it had to come out. So let me give you a little bit of background. We cannot do it without mesh. We have, from the various presentations that we've heard yesterday, today, we have to put mesh, and this is very well known data to everybody. We know that with suture repair alone at 3 years, the recurrence rate is almost 43%, and it goes down to 24% when we use mesh. And then, if we follow those patients all the way to 10 years, the recurrence rate is now 63%, and it goes down to 32% when patients have mesh. And then this is very interesting data. This is from the late 1990s, and we know it, but we've overlooked this data, which is very important. Now, if you look at all clean cases, and ventral hernias are clean cases, the incidence of surgical site infection is 1.5% for all clean cases. But if you separate ventral hernias, the infection rate goes up to 18%. And then if you take those ventral hernias and you look at those patients who had a previous infection and now you're repairing them again, the infection rate goes all the way up to 41%.